In the doorway of the neurology clinic, Dr. Colin Quinn can look at you and tell whether you have ALS. He won't necessarily admit it, but it's true. And it's true of a number of neurologists when dealing with patients within their specialty. There's a gestalt, a gut feeling, that doctors have when they meet a patient for the first time. It's a skill you can't teach, but it's one you can learn. Unfortunately, this skill, this talent, it's unidirectional. From that same doorway, Colin can't look into himself and say with any degree of certainty, something's wrong with me. But something was. About a decade ago, as a neurology resident in Philadelphia, at the same place where I'd just completed my own training, Colin got sick. He should have known it, and maybe he did know it, but he denied it. Had he been a patient and not a physician, he probably would have figured it out sooner. But doctors, we're a little different. We make the worst patients. It has to do with the way we think of ourselves, the way we underplay our own symptoms, and how after years of seeing the worst in physical health, we could never imagine that, one day, we'd be needing a doctor ourselves. But we'll get to that in a minute when BrainWaves continues.
This episode was brought to you in part by Audible. With nearly 200,000 ad-free audiobooks, I'm sure you'll find something you'd like. I recommend Brain on Fire by Susanna Cahalan. It's the story of a Washington Post reporter who describes in vivid detail her battle with anti-NMDA receptor encephalitis. To hear this book and get your free 30-day trial, go to audibletrial.com/brainwaves and sign up. The first month is free and less than $15 a month for each subsequent month, with no cancellation fees. So take a minute to sign up for free at audibletrial.com/brainwaves.
Jim Siegler here. We've got a really incredible show for you today, something a lot different than what we usually do for BrainWaves. And to help me, I've invited a friend, Dr. Travis Lewis, to commentate on this story of Colin Quinn's. Travis, you want to tell us a little bit about yourself?
Well, I have an MD PhD, so I've been interested in movement disorders, and I'm interested in translational therapeutics, so different ways to treat neurodegenerative diseases.
Cool. So we're going to get a move on this case then, with your experience.
Something like that.
So today we're going to be talking with a neurologist who knew he didn't have Lyme disease. Well, I'll let Dr. Quinn tell it.
What I remember was feeling hot. That was actually what I felt first. I just felt very warm. And I probably should recognize that warmth and fever are the same thing. This happened for a couple days in a row where I was just breaking into a sweat. And I kept telling, not yet my wife, Pallavi
Kumar, who, like Dr. Quinn, was a physician. So, Dr. Kumar.
My name is Pallavi Kumar. I'm an oncologist here in Philadelphia. I met my husband when we were interns back in 2007.
She was in her medical residency at the time, so naturally Colin told her about his symptoms.
That I felt really, really hot, and she felt me, and she said, that's not hot, that's actually, you have a fever. So I kind of just ignored that initially. Ignoring symptoms is going to be a real theme here, and probably a theme with many doctors who get sick. So after a couple days of that, at one point, I noticed that my belly button was glowing really red, and I showed it to Pallavi.
We had been dating for about 9 months or so. Yeah, we were pretty serious.
And she said, I think you have Lyme disease. And I said, there's no way. We live in Philadelphia. That doesn't make any sense. And I think that this rash is really nonspecific.
But I think we are all exposed to patients who give you a list of symptoms. And as you hear all those symptoms, you put weight on each one. And there are certain symptoms that are red flags. You put all your weight behind. And there are other symptoms that you maybe keep in the back of your mind, but in general ignore. And so I guess I would say our job as a doctor is to listen to somebody as they describe their symptoms, and then to piece the story together and help drive them into a story that makes sense, that fits some sort of diagnosis. And we do that in a very kind of regimented way in the clinic. But when you're not asking those questions directly and you're just living your life, I can imagine the pieces not falling in place in the same way.
My number one concern right away in telling the story is that it, number one, makes me look like an exceptionally bad doctor, which is fine, but more importantly, it makes my wife look like a bad doctor.
I did urge him to seek medical attention.
And I think that one of the reasons she hates this story is because she feels bad that this took as long for us to arrive at the correct diagnosis.
But had Dr. Quinn been at his own clinic, heard this story, seen this patient, and gotten this history, which, by the way, we haven't told you yet, he was clearing brush in upstate New York just 2 weeks prior, Dr. Quinn might have known that the warmth he'd felt was more than just a fever. He would have at least tested the patient for Lyme disease. But for him, there was no tick, so no Lyme disease.
I just ignored it.
Well, certainly finding a tick is like a smoking gun, but there doesn't have to be a tick, and I imagine most of the time there is not.
I really would have felt stupid if there was a tick. And then I was on call, and the only point in that portion of the illness that I acknowledged being sick was post-call. I was standing over my note, and I was essentially swaying from feeling ill. So I went down to the emergency department, actually, and I said, I really feel sick. And they said, yeah, there's been a lot of flu going around. I mean, it was very odd. So I went home. I was post-call, but I basically just didn't round. I handed off my notes. And I developed what I had diagnosed at the time was a secondary sinusitis. So I thought I had flu, cold, and then I developed a secondary sinusitis. But in retrospect, my secondary sinusitis symptoms were real pain with moving my head. Basically, moving my head or moving my face at all.
So meningitis.
Yeah, sounds like nuchal rigidity to me.
Yeah, slam dunk. But, which one of us has experienced nuchal rigidity?
I can't say that I have. I feel like I've just got arthritis in my neck sometimes, and it gets stiff.
Here I am. I've got, my head over a pot of boiling water trying to clear out my sinusitis. But it's really hard to hold your head over a pot of water when you have meningitis because it really hurts to flex your head over the pot of water. So Pallavi comes over, and she's appropriately kind and sympathetic, as she always is, but she asks to look at my belly again, and now it's evolved from a very red belly button to a red belly button with a white ring and then with a red ring around it.
It does sound, like the bullseye that we're all kind of trained to keep an eye out for.
I mean, it looked like the symbol for Target.
And this is what Pallavi was concerned about earlier.
She said, that's Lyme disease. And I said, there is no way. I do not have Lyme disease.
He did. He actually used those very words.
Yeah, that's ridiculous.
And then my response to him was, that's funny. I thought that was like the most sensitive rash in the world.
It's the thing that everyone's taught. I think if you don't find it, it doesn't necessarily help. But if you see it, I think it's quite sensitive. There aren't a lot of other processes that give you something like that.
Yeah, I don't think of anything else when I see it.
But I did have at least the inclination somehow, I think, for me to get a Lyme test.
Okay, so finally some sense gets knocked into him.
Yeah.
Travis, could it be anything else?
I mean, you take away the rash and, there's lots of infectious processes, viral illnesses that can cause fever, the flu.
So maybe an aseptic meningitis or something. He would have been really sick if it were bacterial meningitis.
Mm-hmm. And he slept on his pillow wrong that week.
Yeah, he's on call. He probably didn't even sleep very much.
Exactly. Well, those call room pillows are rough.
So he tests himself for Lyme disease.
All right, so I'm on call. I look, and the Lyme is negative.
What the
I mean, there's no way, right? It doesn't, it's, what is it? Walks like a fish, talks like a fish.
Where did fish come from?
I always defer to fish.
Fish. Because they walk.
I don't trust ducks with those web feet.
I mean, personally, I've never been more convinced of a Lyme disease case. But if it wasn't Lyme disease, I guess it could have been something else. We'll get to that in a minute when our story continues. We would like to thank Audible for its support of the BrainWaves podcast. With over 180,000 audio titles available to stream, there's plenty to choose from. I recommend When Breath Becomes Air by Paul Kalanithi, the heartbreaking and yet beautiful account of a young neurosurgeon in training who dies from lung cancer. These and other stories can be yours for a free 30-day trial at audibletrial.com/brainwaves. That's audibletrial.com/brainwaves.
I was on call again, and I had it's very busy, as you are well aware. It's very busy at our hospital, so I had a few consults to do, and I saw a woman who had monocular, not diplopia, triplopia, which isn't really a thing unless you have some sort of weird retinal phenomenon going on, which you can address in some other podcast.
Oddly enough, we did just cover triplopia a little bit with Dr. Aguirre in the prior episode, the episode on the mind's eye. But Dr. Quinn was seeing a patient complaining of monocular triplopia, so it had to have originated in the orbit at least. And at this point, he's about 7 or 8 days into his symptoms, into his third call cycle. The first call cycle, as you remember, he noticed symptoms like feeling hot. The second call cycle, he tested himself for Lyme disease, and now he's feeling a little bit better, if only because he knows he doesn't have Lyme disease. So he pulls out his handy-dandy ophthalmoscope to look into the woman's right eye.
You know, when you look in someone's right eye, you look with your right eye and close the left eye. And I went to do that, and I realized that I was still seeing something out of my left eye.
He could still see out of his left eye because it just wasn't closing enough, which is something he told me he really appreciates now as a neuromuscular doctor. You see, because people who have true weakness, they don't really feel weak. They are telling their muscles to do something, but the muscles just aren't doing what they should be, or with the power that they should be. Dr. Quinn was commanding his eyes to close. He's commanding those orbicularis muscles to contract, which are stimulated by the facial nerve. Remember from episode 42, check that out. But the muscles weren't responding.
Exactly. I mean, that's exactly what like central weakness is, and it's something that we know cognitively is what's going on, but it's very hard to imagine.
I think, again, I probably should have been more alarmed by that, but as you know, it's busy. So I just kind of said, that's really strange. I have 2 more consults to do. I'll deal with this later.
You'd think Colin was just acting tough.
I guess during call, we all kind of pick up a superpower or two because it's you go deep into into the drive.
This is exactly the mentality that many physicians have. We're up to our elbows in denial when it comes to our own health. We're drowning in it. We don't know when to quit, and we think we're invincible. Travis, I really like one of these quotes from a paper that I read. Doctors tend to minimalize and intellectualize their symptoms. And all I can say about this is I can't wait to intellectualize all over this case when Colin finally tells me what he has.
I went back to the resident room, and I had an actual moment where I said, "You remember that time where you couldn't close your eye? That was really strange. You should try to close your eye again." And I tried to close it, and it would not close. And then it suddenly sinks in. I mean, it could only be one thing about 7 things ago, but now it really can only be one thing. So I turned, and there's a window in the resident room, and when it's dark outside, obviously it's more reflective. So I tried to smile, and my smile was completely asymmetrical. The left side of my face did not move at all.
Wait, so why is this not Lyme disease again? Fever, meningismus, erythema migrans, and a Bell's palsy?
I mean, it can always be Lyme disease. I mean, there's probably a lot of great viruses out there that we can that can cause some of these things, right? So, I mean, the bigger things are when you think of a facial nerve palsy or a cranial nerve palsy, or you worry about something in the subarachnoid space. So here you're worried about leptomeningeal carcinomatosis. I mean, in cancer, infection. The history, though, I mean, totally makes cancer low and unlikely. And and there's some inflammatory process. Could it be? Again, I think it's hard to broaden the differential here.
I mean, it makes me wonder if the lab had not run the Lyme test correctly, because there's no way it couldn't have been negative.
But it wasn't actually negative. I misread it. This is I do look incredibly stupid. So the way that the reference reads, I did actually complain to the lab about this because, and it turned out I'm not the only one who had given them feedback about this. The way that it reads on the electronic medical record is Lyme reference column negative, right? And in big bold letters it says negative, and then there's a star that you're supposed to click on that has the actual result. Yeah, it was a positive Lyme test. So for the people who believe that no Lyme test comes back positive, this was positive. I swore. And I immediately went upstairs because my future wife was on call in the MICU. And I said to her, "Look at my face." And she just burst into tears. I always tried to smile, and she just started sobbing.
I think what I actually said to him was, "I think I'm going to kill you." Because I was so mad at him. He showed up with a facial droop, which he developed sort of acutely while examining a patient, if I recall. And when he showed up, I definitely didn't feel as, sort of I told you so as I thought I would. I mostly just was really mad at him because he had allowed himself to develop CNS Lyme.
And then as she's crying, I was like, I just want to be clear. Are you upset because I'm sick, or are you upset because I'm ugly?
That definitely crossed my mind.
And she said, she was very honest. She said, honestly, it's a little bit of both. Like, you look horrible, and I feel bad that you're sick.
Because I think one of his amazing physical attributes is that he has a very symmetric face, and this is obviously kind of a big blow.
So, he's still on call overnight at the hospital. Dr. Quinn rings up the next two most important people to him at this point. The hospital's on-call pharmacist, who gives him a dose of doxycycline.
That's the perfect answer.
And then his attending.
He picks up the phone. He's like, "How's it going?" A little small talk. And then I just said to him, "Dr. Markowitz, I have Lyme disease. I developed facial palsy, a half an hour ago. And do you think we could do an LP after rounds tomorrow?" And he was like, "Oh, sure, no problem." Now, Clyde Markowitz is like the master of LPs. He's the one who, runs the LP clinic for the residents. So I was pretty lucky that he was on call.
What's amazing to me is how quickly he just believed you. I mean, I might have thought you were being hysterical, but...
Oh, yeah. I mean, it's a pretty believable... I told him the fundamental, fever, meningitis, target rash, facial palsy.
Well, and again, he was presented the story in a linear, logical fashion as we would, ascertain the story from our patients and then reproduce it to our attending. And that's exactly what he did. He reiterated his story to Dr. Markowitz in a linear, organized fashion that I'm sure laid out the diagnosis at his feet.
And so you wrap up your work overnight. What happened the next morning?
We rounded on all the patients with my very flat left face and, everyone giggling occasionally at me. And then we all walked to the neurology clinic and Clyde Markowitz did a lumbar puncture. It was absolutely painless, but I have to say I can definitely relate to the nervousness of someone sticking a needle in your back. It is an odd sensation.
So Dr. Quinn got the LP, and there were a few white blood cells, calm after the storm of the past 8 days of this suppressed suffering, his meningitis. And I have to admit, it was kind of anticlimactic. But then, after he's been up all night, dealing with this facial paralysis, and his future wife now starting to doubt the future of their relationship, he does what any neurology resident really does not want to do when they're feeling ill and they're post-call. He admits himself to the hospital.
I actually wrote my own admission note because I had to be admitted to get the dose of ceftriaxone.
He actually admits himself to his own service.
To my own floor, the floor that I had just been admitting patients to, hours before I admitted myself.
And he deals with all the things that the typical patient has to deal with. Things like frequent interruptive nursing assessments, painful IVs, and, the food. It's not the best where we work. But he gets his one dose of IV ceftriaxone, and boom, out the door.
I got my discharge. It was so weird to have to go over, discharge paperwork. Pallavi and I went out for dim sum, vegetarian dim sum, and I had soy. It was so strange. I was trying to eat dim sum. We've had this really weird night. I'm happy to, you're always happy when you leave the hospital after a 30-hour call, plus an admission of yourself. And every time I try to eat, the soy sauce is running out of the left side of my mouth. I learned as I was going to kind of account for the fact that the left side of my face was not cooperating, but the first couple of bites of soy sauce did not go well.
But the rest of the story did go pretty well. The next day, he had the pick placed, and he got a full course of, a month of intravenous ceftriaxone. After that, it took a couple of months before the facial palsy really normalized, and now only Pallavi can really tell that his face is still a little bit affected from this Bell's palsy. It's a pretty crazy story, right?
Unbelievably crazy, yeah. It's perfect.
And the one thing that I'm taking away from it is that you shouldn't ignore your symptoms. You shouldn't elaborate them, but definitely don't ignore them. Especially as doctors, because we're awful at it.
It's funny, in neurology, it's never Lyme. It's just as he said, the Lyme test is always negative. Lyme. Lyme is on the differential because it can do lots of different things, but Lyme is also in the public sphere, and everybody thinks they have Lyme, and so it's one of our biggest challenges. So this is a beautiful case of textbook Lyme.
Right. So for all the people out there who think that they have chronic Lyme, it's probably not chronic Lyme. This is Lyme disease, headache, nuchal rigidity, feeling crummy, Bell's palsy. This is Lyme disease. All right, and Travis, before we wrap up real quick, what's one thing that you took away from this story?
I think it brings to bear exactly how we ignore ourselves, and maybe the importance of putting the story together in a linear fashion. I mean, we all, as residents, we think our attendings are brilliant because their differential is we've been thinking about a patient for hours, and the next morning they come in and you present it to the attending. But we're getting information from a patient that doesn't have any medical experience, and they're just telling stories. And our job is to make it concise, make it clear, make it linear and relatable. And so, I think the importance of as we're all moving to becoming attendings ourselves, the importance of taking a step back, looking at the whole story. So I think there's a lot of great lessons.
I couldn't have said it better. And for all of you out there who are listening, Colin Quinn, Dr. Quinn, he's doing fantastic.
I still have some facial asymmetry.
But he's doing great. They've got 2 adorable kids and no chronic Lyme disease. Huge thanks to Dr. Colin Quinn for sharing his story, and to his really incredibly patient wife, Dr. Pallavi Kumar, for allowing him to.
In retrospect, it was actually really funny, but at the time I was like, what is going on?
The episode this week was produced by me, Jim Siegler, with the help of Erica Mejia. Music was courtesy of Siddhartha, Little Glass Men, and Lee Rosevere. BrainWaves is supported in part by Audible, your source for audiobooks. Go to audibletrial.com/brainwaves to get your free 30-day trial and pick from over 180,000 titles. I'm Jim Siegler. Talk to you next week.